Welcome also from my side. It's a great pleasure to have more than 100 participants and of course a great panel. First of all, I would like to thank, of course, our sponsors who make this possible, but of course our international board who is always supporting us and being present, and the panel which we introduced now for the first time here in this part. So we have 4 cases to present. We start with a pathology case, then 1 case from surgery, then radiation oncology, and then medical oncology. And the intention is that the panelists from each respective discipline, they will comment on the case, and then we have the discussion among everyone. So without further losing time, I would love to have Bernadette now starting with the pathology side. Bernadette Liegl-Atzwanger is from Graz and the pathologist there, and we also know you in this context. So please go on, Bernadette.
Well, thank you very much for inviting me, and you told me that I can choose to describe a case or to go more in detail of one part of pathology. I decided to talk today a little bit about sarcomas with round cell morphology, because I loved the talk Beata Bode gave last time about the myxoid lesions. And I thought I will talk today about round cell lesions and some diagnostic issues we have in pathology to solve these lesions. And I decided to pick different tumor entities. I picked the Hewing sarcoma and the CIC DAX4 rearranged sarcoma as part of the tumors out of the round cell undifferentiated round blue cell tumors of soft tissue and bone. And I also decided to pick a fully differentiated synovial sarcoma, a high-grade myxoid liposarcoma, a mesenchymal chondrosarcoma, and the alveolar myosarcoma. And the role of pathology is quite clear in the treatment of patients with soft tissue sarcomas. And the expectations you as clinicians have are also quite clear, because you want to have a diagnosis. And usually you want to have the diagnosis very fast. Our diagnosis should be accurate, reliable, and reproducible. And most of the time you also want to have included already the molecular genetics of the tumor. So yes, we can do so, and we can provide you with all these informations. And also with the help of the recent WHO soft tissue and bone tumors. And we all know from side of pathology that a lot of new genetic stuff is in this book, and that the genetic results helped us to neatly define some tumor entities and also to define new tumor categories. But I think we have to keep in mind that the molecular genetics should not be the driving force in the diagnosis of soft tissue tumors. Therefore, I think we should go a step back and think, how is our diagnostic process? And the diagnostic process for me as pathologist is that I would like to put together chick puzzles, and these chick puzzles are put together under the microscope to a good diagnosis. And to do so, I need clinical information. I really rely on morphology. I like to include immunohistochemical panels according also to the clinical information I have. And then I like to confirm my diagnosis or to separate differential diagnosis by molecular diagnostics. But also we as pathologists have needs. And over the last years, we get less accurate clinical data when we diagnose soft tissue sarcomas, and especially if we are dealing with consult cases from outside. So it is really relevant to get good clinical data, to get knowledge about the relevant imaging stuff. And also it is very, very relevant that we get enough and sufficient tissue, because most of the time we do our initial diagnosis on biopsies, and these biopsy tissue must be properly fixed to provide a good diagnosis. So tumors with round cell morphology, we do not only have in pathology this group of undifferentiated small round cell tumors in the differential diagnosis. We have a lot of other tumors in the list. One of those, I have already said, one part of those like alveolar Mixoid liposarcoma, poorly differentiated, but we also have to deal with carcinomas, we have to deal with melanomas, we have to deal with lymphomas, and we need clinical information upfront to use good IHC panels, and this is essential to spare the tissue for further analysis. So at first I would start with two members of these undifferentiated small round cell sarcomas of bone and soft tissue. And I start with Hewing sarcoma because I think it's the prototypical example of all round cell sarcomas, and giving the name more or less to this group. But with small and round cell tumors, the classic example in Hewing's is that we are dealing with monomorphous tumor cells with small round nuclei and fine granular chromatin, and we do not appreciate nucleoli. We can see some tumors with clear cytoplasm because of the glycogen, and we can see some more neuroectodermal differentiation by seeing these humor-white rosettes. But overall, the immunohistochemistry for Hewing sarcoma is not specific, so there is no specific marker. We need a bundle of different immunohistochemical stains to rule out differential diagnosis. And we all know that in Hewing sarcoma, we can find expression of keratin, S100, and other stuff. We very much rely on CD99 and the new marker, the NKX2.2. However, none of these markers is specific. If we see a tumor, however, with this clear CD99 positivity in most of the tumor cells with this membranous staining, and in addition nuclear staining for NKX2.2, we are on the right track, and molecular genetics confirm the diagnosis of Hewing sarcoma, and I think in this group we really need this molecular genetics for confirmation. We have learned a lot about this molecular stuff, and also the molecular stuff tells us that we have Hewing sarcomas with this classic pattern, which is mainly, these are the Hewing sarcomas with EWSR1, FUS, and FUS fusions with FLY1 or FAF, but there are also other Hewing sarcomas where we have as partner ERG, which are morphologically much more heterogeneous. We also learned that we get some insights about the prognosis of these tumors by looking at the fusion partners. And so Christina Antonescu presented in her paper that, for example, Hewing sarcomas with EWSR1 FAF fusions are more commonly located extraskeletal and have a more aggressive behavior. Then we also know that we have within the Hewing family tumors which have been in the past called atypical variant of Hewing. And we know now that if we are talking about atypical variants of Hewing, we should think of another clearly molecular defined entity called the CIC rearranged sarcomas. And when we look at these pictures Christina Antonescu presented in her paper, then for us as pathologists, it's quite clear that this is not really the classic small round cell tumor, but this tumor entity has a morphologic variability. We can see small cells, epithelioid cells, we can see myxoid changes. And if we have seen more of these tumors, a quite good characteristic or morphologic characteristic of these tumors are these huge geographic tumor necrosis. If we go more in detail, we see much more heterogeneity of the individual tumor cells, where tumor cells are varying in size and shape. And if we go more in detail, we even see the distinct nucleoli, which we would not see in a classic Hewing case. So if we have these morphologic features, we can provide different immunohistochemical stains. And also for the CIC rearranged sarcomas, there is not one single marker bringing us on the right track. It's again a combination of different IHC markers. And in a contrast to the Hewing sarcomas, where we have this really diffuse CD99 expression in most of the tumor cells, the CIC rearranged sarcoma shows more spotty and patchy CD99 expression in combination with WT1 and ETV4, but also a lot of other markers like cytokeratin, ERG, calretinine can be expressed in these tumors. And if we have the morphology and some immunohistochemical hints towards the chick rearranged sarcomas, these need to be confirmed by molecular tests. And in these cases, also NGS technologies should be preferred over FISH or RT-PCR. It's also essential to separate all these different tumor entities because they have a different different prognosis for the patients we are treating, because most of the studies nicely demonstrate that these CIC rearranged sarcoma do worse than the other sarcomas in this group. However, there is one group also put into this undifferentiated small round cell sarcomas of bone and soft tissue, and this is the group of round cell sarcoma with EWSR1, non-ETS with non-ETS fusion, fusions with non-ETS fusion partners. And there is one group, the EWSR1 FUS with NFAT-C2 fusions. And I think these tumors are very likely not to be round and not to be really very small cell. We have here a very heterogeneous morphologic pattern. Some of them look more like myoepithelial tumors, and more tumors with these fusions are popping up. And I think that not all of these tumors should be put really in a sarcoma category. And we have seen in grads also cysts, which are not typical for the simple bone cysts, which have been now described to have these fusions. They have some different morphology, but I do not think that all these tumors which we are seeing are really clear sarcomas. And here really more insights and sharing these cases would be very essential to treat our patients properly. Poorly differentiated synovial sarcoma is one of the differential diagnoses in this group. And if we as pathologists look very closely to morphology, we find some differences in correlation to Hewing sarcoma, because the tumor cells are more oval. They show overlapping nuclei. We see some collagenous fibers in the background and HBC-like vascular structures. And with the molecular knowledge, also new antibodies have been designed against these fusion-specific antibodies, like the SS18 SSX antibody, which is helping in the diagnostic process a lot. So, and these are two different antibodies proposed to be used in synovial sarcomas, and I like to use these antibodies, and they are performing very well. So another diagnostic issue is the so-called high-grade myxoid liposarcoma, the former known round cell liposarcoma. And I'm convinced that in a lot of instances, we will be able to solve this very easily if we as pathologists get core needles from different areas of the tumor. And all pathologists, I think, will agree that if we see like this myxoid background in the chicken wire vascular structures, we see the pulmonary edema-like pattern, that it is not a problem to see other areas with pure small round cell morphology. And we can also do, and as we can also give the diagnosis of myxoid liposarcoma high grade, However, if we do not have any imaging results, we do not have any information, and we get only a biopsy with this round cell morphology, it gets much more tricky for us because we have to search then for individual lipoblasts or for some vessels in the background. And God thanks, there is also some new molecular-based IHC marker on the market, the DDET3 antibody, which helps in these circumstances. Otherwise, there are no good antibodies for myxoid liposarcoma, and to select then a pure round cell liposarcoma, it's only possible with molecular genetics. Another huge issue is one of the very, very rare tumor subtypes, the mesenchymal chondrosarcoma. And if you see this gross image from pathology, it's again clear that if we have biopsy material out of different areas of this tumor, we might solve the problem very quickly, the diagnostic dilemma, because we have then the small round cell component, which would be seen in the yellow circle. We would have these glistering areas reminiscent for the cartilaginous areas, and in the dark blue circle and in the light blue circle, we have more these calcified areas. And on this screen, you can see that if we have both components, the diagnosis would be clear. Again, here, by depicting both components, I think there is not a big diagnostic issue. But if we only have the round cell component, it's quite similar to Hewing sarcoma with the same immunohistochemical staining for CD99 and even NKX2.2, and then only the molecular diagnostics will help to solve these problems. Alveolar rhabdomyosarcoma as last variant, especially the solid form of alveolar rhabdomyosarcoma, is also in the differential diagnosis where you have sheets of blue tumor cells, and we have to search for some rhabdomyoblasts and some cracking artifacts. And if we find them, we will pick the right antibodies like desmin and MyoFD5, and we'll have very quickly the exact diagnosis without even having upfront the molecular pathology results. So to sum up, I hope that I was able to show you some issues in diagnostic pathology and some hints how you as clinicians can help us to solve these problems. I think that we can provide accurate, reliable, and reproducible diagnosis by putting together all chick puzzles, and molecular diagnostics, at least in my view, should be one part of the chick puzzle, but should not drive the diagnosis up front. So I think we agree that there is no treatment without pathology, and that all the patients suffering from these rare tumors should be treated in specialized center by a multidisciplinary team. And I'm very grateful that I am able, that I'm allowed to work within this interdisciplinary team in Graz. And I thank you for your attention.
Bernadette, the applause is yours. Thank you so much for this really comprehensive overview, impressive. Now I would like to ask the pathologist from the panel, who is Gunhild Mechtersheimer from Heidelberg, and then Beata Bode from Zurich, to comment on what Bernadette just told us. Gunhild?
I restart. So Bernadette, thank you very much for this very, very interesting and helpful overview. So I think Bernadette, she is right. We essentially need the clinical information in those cases, and I'm not sure what I should ask you concerning pathology. I think it was very, very clear. We need molecular diagnostics. But my question is, are you really, is it really true that the fusion-specific or translocation-specific antibodies work really well and without pitfalls?
So the SS18 SSX antibody, the fusion-specific antibody, at least in our hands, is working very well. I have only seen one example of ours without any positivity turned out to be a synovial sarcoma. But overall, as a screening marker, it works much better than the DLE1 antibody. And I think especially in the very poorly differentiated, where we only see very faint and focal keratin or EMA expression, it is helpful. The DDT3 antibody, I'm a little bit more cautious because in our hands, it's also staining other entities in the differential diagnosis. So I do not rely at this moment on the antibody we have, but there is another paper out with an EpCAM antibody, so I will try. But the SS18 SSX antibody is working very good in our hands.
Okay, thank you. May I ask two small questions? Two additional. Okay. First question, in pathological practice, do you rely on the antibody or do you also perform NGS-based fusion analysis? This is the first question. And the second question is, which platform do you use for NGS fusion analysis, and how many days takes it to have the results?
Okay, so we do molecular confirmation for for mostly all the cases we have, and we do the Archer fusion black sarcoma panel, and it's working very well.
The turnaround time is?
The turnaround time is approximately 1 week.
Oh, that's good. Thank you.
Okay, perfect. Thank you, Gunhild. Beata?
Great, Bernadette. It was a great overview over these complex topics. It's well, it's also clear when you have the stains and the molecular testing, but to arrive there, it's not that easy. And we know that we encounter very interesting and funny cases. So in my experience, the most challenging thing is to rule out that it is not a sarcoma. Because we are usually, you know, we have the sarcoma and then we're dealing with the tumor. But you know, to rule out that it is not a sarcoma or rule in it is a sarcoma, it's quite a challenging. You mentioned also at the beginning of your talk. And what's your experience? How often do you see it in your consults that you know something submitted as a sarcoma is not the one, or you know, a carcinoma which turns out to be a sarcoma?
Most commonly, I see melanomas. So in that it turned out to be not a sarcoma, it is a melanoma, and these are mainly tumors which only express SOX10 and a little bit of S100 without any expression of HMB45 and melan A. So I get these cases, and I commonly get cases from the lung with spindle cell morphology. Then it's becoming more tricky because there we have also this marker for deficient tumors, and most of them are
sarcoma or not
deficient carcinoma. So yes, you have to be aware, especially if you deal with the consult cases are tricky because the informations are quite poor in most of the cases, and you cannot go to your in-house system and look up the radiology and look up a little bit the clinical history. So that I would like to have more information from the outside consultations.
These are all
and I
very
think this
important.
is really important point that the sarcoma diagnosis is confirmed. Yeah. Okay. Thanks.
Very important teaching point. Please, Philip.
A short question, just from a clinical point of view. If our differential diagnosis is a melanoma and we won't find the primary lesion, will you always be able to differentiate or exclude melanoma from a pathological point of view?
So if I have like a tumor only in the soft tissue, but it is expressing clearly SOC10 in 100% of tumor cells, and I do not have an epithelioid morphology, which would also have a epithelioid MPNST in the differential. So I prefer, or I sign it out, it's most likely melanoma, and I perform the molecular tests. And in most of these cases, you find also the genetic changes.
May I ask now the board, Axel, Javier, Jean-Yves, to comment from their perspectives on a broad range as non-pathologist specialists?
Thank you, Bruno. It has been very, very nice talk, Bernadette. Very enriching talk. I was wondering about the myeloepithelial malignant tumors, which can be also in the differential diagnosis with other small round cell tumors. So always we have the difficulties to consider this a true soft tissue sarcoma or not in the cases where this tumor can arise in soft tissue or even in different viscera. But usually these cases are referred to medical oncologists in charge of soft tissue sarcoma or sarcoma in general. And actually, in some cases, we have seen dramatic responses, for instance, with Hewing protocols with chemotherapy. So according to your point of view, this should be a soft tissue sarcoma, this should be a carcinoma, or this should be another different entity or unclassified entity, as you can see in the case of malignant phyllodes, for instance. What is your opinion about that? Have you mentioned that in the differential diagnosis? And I was very curious around your point of view.
That's a very tricky question. So the myoepithelial tumors are one part of the soft tissue, or are one part in the WHO classification. I don't think that these are really carcinomas, but I only diagnose myoepithelioma or myoepithelial carcinomas very, very rarely, and I do not have, so I don't know, but maybe Joanna can comment on this if we have ever treated one. So I have limited experience, but we do all the molecular testings. We rely then on also on the EWSR fusions we find in them. But I see on morphology an overlap between these myoepithelial tumors and especially this group of small round cell tumors with EWSR1, this NFAT-C2 fusion tumors. There are tumors with morphologic overlap, because I've seen one which looked like myoepithelial for me under the microscope, and when we did the molecular testing, then it turned out to be in this subgroup of tumors. But I have really limited personal experience to answer this question.
Okay, well, thanks so much. And